Hi students, hope you are all doing good. Now in this video, we are going to see about the second trimester and third trimester ultrasound findings. Okay, we will also see about the Doppler findings and the signs of intrauterine death. Okay, also. Now we'll start. So, it is second and third trimester ultrasound. Okay, together I am going to discuss in a sequence. Okay, now let's see the indications. Okay, so what will be able to assess? Okay, why we are doing this? Number one, we'll be able to determine the fetal number. Yes, including the chorionicity and amniosity of the fetus if it is a multigestational pregnancy, right? Then you will be able to assess the fetal cardiac activity, okay, fetal presentation, that is also very important, right? Then the placental localization, then about to the cervix, okay, especially the cervical length. Then we'll also be checking on the amniotic fluid volume. Then definitely the gestational age assessment. And fetal weight estimation. And also the fetal anatomical survey, okay, about the congenital anomalies. Okay, so even then we are able to identify one or two congenital anomalies or aneuploidies in the first trimester. A targeted anomaly scan is usually done in the second trimester. Okay, and not the least thing, but at this time you will also be able to assess about the maternal uterus, cervix, and even the adnexa when needed. Yes, so these are the things, and we'll start with fetal biometry. Now, if you ask me, ma'am, what is this fetal biometry? See, these are some measurements of various parameters, okay, in the fetus. To assess the fetal age as well as its growth. Okay, so we'll be discussing about 4 important parameters here. Okay, that is the biparietal diameter, the head circumference, the abdominal circumference, and the femur length. Okay, now we'll see about the biparietal diameter. See, biparietal diameter is the widest diameter of the fetal head. Okay, and this is usually measured between 14 to 20 weeks. How we will be measuring this? See, this is the biparietal diameter measurement, and you see there is an upper caliber and there is a lower caliber. The upper caliber will be touching the outer border of the outer bone, upper bone. Okay, we'll keep this as a upper end of the skull and we'll keep this as a lower end of the skull. So we have two calibers. So the upper caliber will be touching the outer border of the upper end of the fetal skull, and the lower caliper will be touching the inner border. Okay, see here only the inner border is touching. Okay, so the inner border of the lower head of the skull. Okay, so we have a upper caliper that is touching the outer border of fetal skull, and we have a lower caliper that is touching the inner border of the fetal skull. Okay. Now as you see this picture, I hope you will be able to appreciate one arrow mark here. Like this. Yes. Now, while measuring a biparietal diameter, okay, like this, you will also be able to appreciate one arrow mark here like this. Okay. So, this arrow mark should be seen while measuring a biparietal diameter as well as a head circumference. Okay. Now, what are these? Now, this is the thalami and this is the falx cerebri and this is the CSP, that is cavum septum pellucidum, that is seen. Understood? Okay. So, this should be seen. And next one is about the second diameter is the head circumference. Head circumference is measured by the outer borders of the skull. That's all. Okay, if you see biparietal diameter, the caliber is in the outer border here. Okay, and it's dropping with the inner border. In occipitofrontal diameter, that is also the head circumference, will be taking the outermost border of the skulls. Okay, in the occipitofrontal part. And the next diameter is the abdominal circumference. Okay, while measuring abdominal circumference, we are assuming to take a transverse diameter through the upper abdomen. Okay. Now, calipers are placed on the skin surface and while measuring abdominal circumference, image should be circular in shape. Okay. Then stomach, umbilical vein and portal sinus should be visible. Okay. See, for example, this is how you should focus. Okay. So, the image should be circular in shape and fetal stomach, umbilical vein and the portal sinus, okay, should be visible in the image. And remember, abdominal circumference is crucial in detecting fetal growth restriction, that is FGR. Okay. Now, this is because AC decreases when there is a depletion of adipose tissue. Also, when there is a reduced glycogen storage in liver. Okay. And suppose if the AC is more than 35 centimeters, there can also be a diagnosis of a macrosomia can be made. Clear? Yes. So, this is the ultrasound picture where we are focusing on the stomach bubble, okay, the umbilical vein and the portal sinus, and the image is circular in shape. Clear? Now, the next parameter is the femur length. Okay. So, femur length is usually seen as a slightly curved, brightly echogenic structure because it is a bone, right? So, it is highly echogenic or hyperechoic, brightly echogenic structure. Okay. Sometimes we will also be able to identify aneuploidies. Okay. Suppose if there is a short femur length that can be correlated with either aneuploidies or even fetal growth restriction and even skeletal dysplasia. Okay. So, for determining skeletal dysplasia, there can be a comparison between femur length and abdominal circumference. Normally, this femur length abdominal circumference ratio range is between 20 to 24. Okay. Suppose if it is becoming to 16 or less than that, then you can say there is skeletal dysplasia. Okay. So, this is the femur length measurement. Okay. So, this is a brightly echogenic structure and we are going to measure from the top to the bottom. Okay. So, this is how femur length is measured. And coming to the next one, not only this, so many other biometric measurements can also be made. Okay. So, what are the other biometric measurements? We can do check on the foot length or the clavicle length or the transverse cerebellar diameter, the intra-orbital and inter-orbital diameter, and even the length of the bones of extremities. Okay. And remember, most of the time we will be measuring the common 4 parameters what we have discussed so far. Okay. And sometimes this can also be included if needed. Okay. And we will see about how gestational age assessment can be made from the ultrasound. Okay. See, gestational age assessment, okay, in the first trimester, okay, or in the second trimester or in the third trimester, can be done in all the 3 trimesters, okay. In the first trimester using crown rump length, okay. In the second trimester using the biparietal diameter, and in the third trimester we will be using the femur length. Okay. So, it is possible in all the 3 trimesters. But remember, the first trimester dating, okay, is the more accurate dating that you can do. Okay. Suppose you will be measuring it between when there is the CRL measurement is between 45 to 84 millimeter, right. Suppose if it goes more than 84 millimeters, then you have to go for the second trimester BPD measurement. Okay, that will be more accurate. So, if you ask me, among the 3 parameters, among the 3 measurements, which is the most accurate measurement for calculating gestational age, means it is the crown rump length, right. And which is the most accurate measurement of estimating the gestational age in the second trimester means it is biparietal diameter. And remember, this biparietal diameter can also be used to calculate the gestational age until only 22 weeks. Okay. So, when it is going about 22 weeks, you have to go for the femur length. Clear? Okay. And also remember, suppose there is a discrepancy. Okay, once you are calculating the gestational age, it should be compared with the standardized values. So, suppose if you have calculated your gestational age in first trimester ultrasound, okay, and there is less than or equal to 7 days of discrepancy between your LMP and your calculated gestational age, then you can choose the estimated gestational age from LMP itself. Clear? And suppose if there is a more than 7 days of discrepancy between the LMP and the gestational age calculation, then choose your estimated gestational age from the ultrasound measurement. Clear? Yes. The same way, similarly, in a second trimester USG, okay, if there is less than or equal to 10 days of discrepancy, okay, yes, you have to choose the estimated gestational age from the LMP itself. And suppose if there is a more than 10 days of discrepancy, you have to choose the estimated gestational age from the USG data. Okay. So, this is done because not most of the women remember their LMP and they don't come for immediate clinical evaluation and further follow-up once even their pregnancy is confirmed. Okay. Sometimes they may directly come to you in second trimester or even third trimester. Okay. So, that is the problem. So, that is why estimating a gestational age is quite difficult. Okay. So, you have to keep all these criteria. And remember, abdominal circumference is one of the important parameter to assess fetal growth, right? Okay. So, this is mostly done in third trimester. Okay. So, to make it even more clear, in the first trimester, we will be doing a dating scan, that is to estimate the gestational age correctly, followed by NT scan. Okay. And in second trimester, okay, the scan will be doing to we can estimate the gestational age, but it is not the importance is mostly given to the estimation of fetal anomalies. Okay. So, that scan is also called as TIFA scan. Okay. So, that is targeted imaging for fetal anomalies, right? And in the third trimester, we are most concerned about the growth of the fetus. So, it is also known as interval scan or growth scan. Okay. So, this is how it goes. Am I clear? Yes. Now, we will see some of the findings that what you have to do in your TIFA scan. Okay. So, targeted imaging for fetal anomalies. Okay. In this imaging, it is usually done between 18 to 22 weeks. Okay. And 70% of the major and 45% of the minor anomalies can be made out. Okay. And the components, okay, what and all you have to see means you have to see the head and neck, okay. Then the head and neck you have to see about the falx cerebri, the cavum septum pellucidum, how are the ventricles, okay. Then about the choroid plexus, okay, cerebellar hemispheres and all. Okay, then you have to check on the face. Okay, face means importantly the orbits. How is the nose? Is the nasal bone seen? Okay, then you have to include the mouth with the lips, and then we'll be coming to the spine. In the spine, we'll be checking for the ossification centers. Okay, if there is a cervical widening seen or not. Okay, and then sometimes for the sacral tapering. Okay, then thorax, you should be able to make a heart view as a 4-chambered view. Heart should be viewed as a 4-chambered view, and you also check the lungs. Okay, for any cyst or masses if seen, and you have to check if there is any diaphragmatic hernia also. Okay, and then in the abdomen, you have to see how is the stomach, liver, the bowels, okay, kidneys, bladder, okay, and also the umbilical cord insertion, into the fetal abdomen. Then even you have to check the umbilical cord for the vessel numbers. Then you also have to keep a check on the genitalia and even the extremities. Clear? Yes. Now we'll see the fetal anomalies that you can appreciate in the second trimester. Okay. Number 1 is a open spina bifida defect. Okay. So what is happening here is there is an absence of skin covering. Okay. So you will be able to appreciate 2 signs here. One is the lemon sign, that is there is abnormal scalloping of the fetal bones. Then you will be able to appreciate another sign called as banana sign, okay, where there is a crescent shaped, okay, that crescent shaped structure here is compared to the banana. Okay, so crescent shaped cerebellum, okay, and banana sign is a more sensitive sign. Okay, so if you see, you are able to appreciate here, right? So these pics, so you are able to see a lemon like structure. Okay, so this one, and here if you see, you are able to appreciate this thing, right? So there is a banana cerebellum, a crescent shaped structure. Okay, so this is the lemon sign and this is the banana sign that you will be able to appreciate in the case of open spina bifida. And sometimes there can also be encephalocele, okay, which is a case of high spina bifida, okay, and it is one of the rarest form, okay, of neural tube defects, and then it is a bony defect. Now if you see, this is a bony defect, okay, bony defect usually in the occiput region, okay, through which a sac that is composed of dura protrudes. Okay, so you are able to see that, like, so this is the meninges, okay, that is protruding along with some brain tissue. So this is a case of encephalocele. And another one is sometimes you will be able to make up some syndromes like Dandy-Walker malformation. Okay, in Dandy-Walker malformation you have a posterior fossa cyst, and usually there is a hypoplastic cerebellar vermis also. Okay, so or absent vermis also. So this is a posterior fossa cyst. Okay, and there is a absent vermis that is noted. So that is a Dandy-Walker malformation. Okay, and sometimes you will be able to appreciate sacral agenesis also, which is otherwise known as the caudal regression syndrome. And know that it is one of the extremely rare anomaly. Okay, exclusively it is seen in infants born to pre-gestational diabetes mother. Okay, so that is sacral agenesis. Also, I want you to add a point on anterior abdominal wall defects. Okay, see, usually anterior abdominal wall arises from fusion of 4 embryonic folds. Okay, namely a cephalic fold, a caudal fold, and 2 lateral folds. Okay, now suppose if the 2 lateral folds fail to fuse, okay, the physiological herniation that would have occurred, right, the physiological herniation around 8 weeks would have happened, and that should reduce back by 10 weeks. But this won't reduce if the lateral folds are not fusing. Okay, so it doesn't reduce. Okay, so this results in something called as omphalocele or exampholas. Clear? And suppose if the lateral folds are fused, okay, if all the 4 folds fused normally, but again a small defect arises. Okay, that will be mostly to the right of the cord insertion. Okay, then this will give rise to gastroschisis. Clear? So this is omphalocele or exampholos, and this is gastroschisis. Okay, and remember in omphalocele there will be a membrane that is covering the contents of the abdominal cavity, whereas in gastroschisis the bubbles will be just like that lying exposed. Okay, so that's why this is irregular. Okay, so this is omphalocele and this is gastroschisis, which are the anterior abdominal wall defects that can be made out in the target scan. Okay, and now not only this, we are going to study about the fetal environment also, right? So if we see about the fetal environment, we are going to study the amniotic fluid. Remember, amniotic fluid measurement cannot be done in first trimester. Okay, So amniotic fluid, we know the fluid that is surrounding the fetus, and the normal range of amniotic fluid, okay, and what is the range in oligohydramnios and what is the range in polyhydramnios. We have two measurements, one is amniotic fluid index and another one is single vertical packet measurement. And remember, in amniotic fluid index, we'll be taking we'll be dividing the abdomen into 4 quadrants by taking a line passing through the umbilicus as well as the linea nigra. Okay, so this is a linea nigra. So we'll be drawing 2 perpendicular lines over this, and you'll be adding the longest vertical pocket. You'll be measuring in these 4 quadrants, and you'll be adding 1 plus 2 plus 3 plus 4, and you will be finding amniotic fluid index. Okay, remember there should not be any fetal parts or any umbilical cords while you are measuring that region. And also, suppose if you want to measure the single vertical pocket, okay, you will be taking uterus as a whole and you will be measuring the longest vertical diameter that is possible. And remember, AFI is more preferred than SVP. Okay, it is more reliable also, amniotic fluid index. So we'll see the measurements in centimeters. Okay, so the normal measurement of single vertical amniotic fluid index is 5 to 25 centimeters and the single vertical pocket is 2 to 8 centimeters. Okay, so when it is considered to be oligo, amniotic fluid index will be less than 5 centimeters and the single vertical pocket will be less than 2 centimeters. And in the polyhydramnios, the amniotic fluid index is more than 25 centimeters and a single vertical pocket is more than 8 centimeters. Clear? So that is the first thing we will be making. And then we have to see about the placenta. Okay. So if you take the placenta, we have to make up so many things, like either we can make out if there is a placenta previa, okay, or abrasion, or even a placental accreta spectrum disorder. Like in common words, we can tell it like if there is a adherent placenta or so. Okay, so placenta previa means normally the placenta is attached in the upper segment of the uterus, right? Suppose in any cause the placenta is lying in the lower uterine segment, then it will be called as placenta previa. Okay, so these are the 4 types of placenta previa. You have a low-lying placenta, okay, then marginal placenta previa, partial placenta previa and complete previa. Now, this classification is not generally used. What we use is low-lying placenta, and all these 3 categories together are known as placenta previa. Clear? Okay, a low-lying placenta means from the os to the placenta, the distance should be at least less than 2 centimeters. Okay, and these are the cases of placenta previa where the placenta is going to touch the internal cervical os and it is going to partially close the internal cervical os and it has completely closed in the internal cervical os. Clear? Yes. Now also we can know about placenta, adherent placenta. Okay. So there are 3 categories of adherents also. It is placenta accreta, placenta increta and perfreta. Okay, accreta, increta and perfreta. Okay, remember accreta, usually the placenta should adhere itself to the endometrium only, right? So that it will be shed off after the pregnancy completely. In any cases, if the placenta is going to invade through the myometrium, suppose if it is getting itself attached to the myometrium, it is placenta accreta. Suppose it is invading through the myometrium, okay, then it is placenta increta. And suppose if the placenta is perforating itself, perforating through the myometrium and coming completely outside the uterus, and in some cases it may even invade the outside structures also, outside uterine structures also. Okay, so that means perforating the uterine wall and coming out, that is perforating through the myometrium. Okay, so all these things can be appreciated. Okay, so this is a normal placenta, this is a accreta, this is a increta. Okay, accreta means it is adherent to the myometrium, increta means it is invading the myometrium, and periphreta means it has completely passed into the uterine musculature and it is now going to come out. Clear? Yes? Now also, I want you to know about the umbilical cord also. Okay? See, in umbilical cord, you have two umbilical arteries and one umbilical vein. Which umbilical vein is left? Yes, it is the left umbilical vein. So, this is another important thing you have to remember. It is 2 A's and 1 B. Okay, give preference to the first alphabet. So, 2 A's and 1 V. Okay, and which V is left? It is the left V which is left. Clear? Yes. Now, suppose if there is a anomaly in umbilical cord, you have to check for a single umbilical artery. Okay, so which needs evaluation for fetal structural and chromosome anomalies. Okay. So, this is the ultrasound picture to show a single umbilical artery. You have only two vessels. Okay. You have one artery and one vein. There is no second artery. So, in this case, you have to concentrate about if there are any structural anomalies or chromosomal abnormalities associated with the fetus. Right. Next, we will see one of the important evaluation in second trimester, that is cervix. Okay. We are more concerned towards cervical insufficiency. Okay. Now remember, cervical length measurement is usually done between 20 to 24 weeks of gestational age, and it will be around 3 to 4 centimeters, and this will continue till at least 37 weeks. Clear? Now, usually cervical length measurement is measured by a transvaginal approach. Suppose if the value anytime 0.5 to be okay, and competency as the pregnancy. In some cases, you have to balloon the membranes into the cervical canal. Okay, and this is usually known as the funneling of the cervix. Okay, and this indicates there is a chance of preterm labor. Okay, at the same time, suppose if the length of the cervix is more than 4 centimeters, means there can be a chance of post-dated pregnancy also. Okay, and cervical insufficiency is the most important cause of recurrent pregnancy loss. Suppose if you have a case of recurrent pregnancy loss, you have to do a serial measurements of cervical length. Okay, starting from 14 to 16 weeks itself. Okay, you have to start it much earlier and you have to continue till 24 weeks at least. Clear? So, measuring cervical length is one of the most important aspect of doing your second trimester ultrasound. Okay. Now, here I also want to talk upon the soft markers that you will be able to make in second trimester, soft markers of aneuploidy. Okay. So, the first one is increased nuchal fold thickness. Okay. So, nuchal fold thickness means the skin in the posterior aspect of the fetal neck. Okay, and this is usually done between 18 to 24 weeks, and suppose if it is more than 6 millimeter, then it is considered to be abnormal. Okay, and the second one, you may have choroid plexus cyst. Okay, or there can be dilated cisterna magna. Okay, then there can be echogenic mass in the cardiac chambers, or there can be, as we have seen, there can be a single umbilical artery, or there can be ventriculomegaly. Okay, echogenic mass can be seen in the cardiac or sometimes in the bowels also, and then there can be renal pelvis. Okay, short length of the, so there can be femur or humerus. Another importance of marker is absent nasal bone. Okay, there can be sandal gap that is present between the toe and the next finger, and a fifth finger clinodactyly in hands. Okay, fifth finger clinodactyly. Okay, what is happening is there is a hypoplastic or a absent middle phalanx in the fifth finger. Okay, so these are some of the soft markers that you will be able to appreciate in the second trimester scan. Now we are going to another important part of second trimester ultrasound. It is the Doppler in pregnancy. Okay, what is the importance of Doppler ultrasound in pregnancy? See, we will be assessing many blood vessels. Okay, the vessels include umbilical arteries, okay, uterine artery, middle cerebral artery, and sometimes even the ductus venosus. Okay. Now we have to check what we are going to check in these vessels. Okay, we are going to check whether there is a presence or absence of blood flow. Okay, and we have to know about the direction of the blood flow, and sometimes the flow characteristics like velocity and impedance also studied. Okay, now we will see about the flow direction. Okay, now we will see the direction of the blood flow. If you put color in Doppler, if you can have two colors. Okay, one is a red color, okay, another one is a blue color. Okay, and remember, blue color means it is the blood flow is away from probe, and red color means it is blood flow is towards the probe. Clear? Yes. We will see about umbilical artery now. Okay. So, umbilical artery, you know, they arise from allantoic vessels, right? Now, initially in the first trimester, these vessels which are rising from the allantoic vessels are going to have a increased resistance, and slowly after that the resistance is going to reduce. Okay. So, increased resistance is seen in first trimester. Okay. And it decreases in the second and third trimesters. Okay. Now, usually we have umbilical vessels, means we have umbilical artery and umbilical vein, right? So, umbilical artery we have, then umbilical vein we have. Okay. So, usually if you see umbilical artery, you have a sawtooth type of flow, and umbilical vein will be having a continuous flow. Clear? Now, there are certain indices also to measure this umbilical artery and uterine flow. We have some indices called as pulsatile index, okay, then resistance index and systolic diastolic ratio. Okay, just know the names, we are not going into the detail. So, it is pulsatility index, okay, it is resistance index and it is the systolic diastolic ratio. Okay, normally let's take this SD ratio now. SD ratio, when it is less than 28 weeks, it will be somewhat less than 5. Okay, the ratio will be less than 5. Suppose when it is coming around 34 weeks until term, it will further reduce, okay, because the resistance is going to reduce as the pregnancy is going to advance. That's what we have seen, right? So, this resistance decreases and it will come to 3, okay. Suppose in case of IUGR, okay, or if there is a case of placental insufficiency, okay, or when it is leading to pregnancy induced hypertension. In all these cases, what is going to happen is, all these indices are going to increase. Okay, so the systolic diastolic ratio is going to increase, the pulsatile ratio is going to increase, and even the resistance index are going to increase. Okay, now so since these kind of changes are going to happen, we can categorize the umbilical artery Doppler into 3 stages. Okay, the first stage can be where there is absent where there is the end diastolic flow decreases. Okay. Then there is absent end diastolic flow, and then there is a reversal of end diastolic flow. Okay. Remember, when the end diastolic flow is going to reduce, it means there is a uteroplacental insufficiency. And when there is an absent end diastolic flow, it means there is a fetal compromise that is occurring. Fetus is compromised. And when there is a reversal of end diastolic flow, it means that there is an impending fetal death. Clear? Now, what we are going to do is, we basically deliver the fetus at this stage. Okay, so that means if you see the sign, immediately terminate. So, termination of pregnancy. Okay, and if the fetus is in a compromised stage, then you have to give steroids and you have to further follow up. And if it stays in the stage of absent end diastolic flow itself, you can deliver it after 34 weeks. Or suppose if it is converting into reversal of end diastolic flow, you are going to terminate it immediately, right? Okay. Now, that is the importance of umbilical artery Doppler. Now, you see this is the normal umbilical artery Doppler. Okay. So, this is the umbilical artery and this is the umbilical vein, okay, flow. Now, this is a normal one, okay. So, you have a sawtooth appearance and here you have a continuous flow. Now, this is absent end diastolic flow, okay. So, usually this is the systolic flow and this is the diastolic flow, okay. So, this is the diastolic flow. So, what is happening here? The diastolic flow is not seen, right. So, this is absent end diastolic flow, and in reversed end diastolic flow, what is going to happen? This is going to get reversed, right. So, there is a reversal of the diastolic flow. So, when you see the sign, you have to terminate the pregnancy immediately, and when you see absent in diastolic flow, you can give up steroids and you can follow up and you can deliver at 34 weeks. Suppose it is getting converted into reversed in diastolic flow, you are going to terminate the pregnancy again. Clear? Did I make it clear? See, these are some hint points that I want you to combine with the ultrasonogram discussion, but a clear detailed discussion will be made in the respective chapters, right? Now, the next artery what we are going to discuss is about the uterine artery. Okay, usually in the uterine artery only the trophoblastic invasion is going to happen, right? And if there is a elevated resistance in the uterine artery, okay, suppose if the resistant index in uterine artery is more than 2 standard deviations, okay, and there is a persistent diastolic notching, okay, persistent diastolic notching are present, then these are the warning signs. Clear? And if you see this diagram, you will be able to understand, okay. So, this is the normal flow, okay. So, there is no resistance, and how it is coming? There is a normal flow, okay. Suppose there is a persistent notching that is present, and these are considered to be the warning signs, and again it is going to be of the placental insufficiency of pH or FG or anything, right. Middle cerebral artery, fetal anemia, okay. So, there is a peak systolic velocity measurement in middle cerebral artery, and when it is more than or equal to 1.5 multiples of median, then you can know that there is fetal anemia. Suppose I have a twin gestation, and say twin A and twin B. Twin A has peak systolic velocity more than 1.5 MOM. And this twin is having peak systolic velocity less than 0.8 mm. That means, yes, there is a twin to twin transfusion syndrome where this fetus is a case of fetal anemia, okay, and this fetus is a case of fetal polycythemia. Okay, just know the cutoffs, and it is used to diagnose fetal anemia and polycythemia, that's it, okay. And in some cases, you can even evaluate the ductus venosus flow, okay. So, normally ductus venosus flow will be abnormal, okay, in a case of fetal acidemia, and especially when it is severe or a severe fetal acidemia, okay. If there is FGR, okay, if it is diagnosed, we can check the ductus venosus. When the ductus venosus flow is normal, then we can be assured that fetus is not compromised, okay, that is, it is well compensated only. Now, as we have completed about the Doppler studies, now I want to discuss with you about some signs of intrauterine death, okay. So, know about some important signs alone, okay, that you will be able to appreciate in the ultrasonogram, okay. Number 1 is Robert's sign, okay. In Robert's sign, you will be able to appreciate gas in the heart chambers, okay, or even in great vessels, okay, like say aorta, okay. And another sign is Spalding sign. In Spalding sign, there is overcrowding of the cranial bones, okay. Because why? The brain tissue is going to get shrink after the fetal death, okay. So, due to that, there is overlapping of the fetal bones, okay, shrinkage of fetal brain tissue. Okay, so this is the thing. So you have a heart, okay, where you are able to appreciate the gas bubbles, okay, and then here you have a Spalding sign. You are able to appreciate like there is overthreading of the cranial bones, and you will also be able to see the hyperflexion of spine. There can be crowding of ribs, and you will be able to appreciate increased pericranial fat also, okay, and this is known as dual sign, dual sign, okay, so it is dual sign. Clear? Okay. Now I just want to add on one point. I told fetal weight measurement can be done in ultrasonogram, and the formula we use for fetal weight measurement in ultrasonogram is Hadlock's formula and Shepard's formula. Okay, just know the names. And clinically, what is the formula we use? Yes, it is the Johnson's formula. Okay. So with this, we will be completing the discussion on ultrasound. So until we meet in the next video, happy learning, take care and bye-bye.